Thanks everyone for coming this afternoon. We are expecting still quite a few people, but we're not sure what's happening with the weather, so we thought we might as well get started. So thanks very much for joining us for what might be one of the first events for HIV Awareness Week 2014, which is certainly one of the first CSRH or NCHSR, as we were previously known, HIV Awareness Week events. And thinking about sort of what can a research center do that's sort of somewhat engaging and then doesn't involve too much data, we thought we might as well look at the social and behavioral aspects of ending HIV, which of course is where our major contribution to the HIV response will sit, looking at sort of what are the behavioral and social factors and what could be more important under the current climate. Then looking at stigma, discrimination and criminalisation, I want to add to that mix. So this afternoon we have a forum that consists of two parts. We'll first have an opening address, and I'll introduce our opening speaker in a minute, followed by a Q&A type panel with 6 leaders in the HIV response in New South Wales. And Annie has provided most or all or many of you with cards and a pen. And the idea is that I will not be the only one asking questions of the panel, but that there is an opportunity for you to engage with the panel as well. And as we go through Jane's presentation and the panel, maybe questions come up. If you don't want to retain them in your memory, write them on a card, pass them to Carla in particular, and Carla will then do the sort of interactive, she will do the fun part, the interactive part, discussing between you and the panel. Before we go into the actual event, there's a couple of sort of more practical things I need to mention. The emergency exits are straight out the door and to your left, and the conveniences and facilities are just behind this room. And well, before we really start, I'd like to acknowledge the traditional owners of the land on which we're meeting this afternoon. Pay my respects to Aboriginal elders past and present, and welcome any Aboriginal people who've joined us for this forum this afternoon. And then, yes, thanks. And now it's my great pleasure to welcome for our opening address to this CSRH Ending HIV Forum, Jane Costello. Jane is well known to everyone in the audience, and Jane, I'm going to introduce you amongst your multiple roles and contributions as the President of Positive Life in New South Wales. And thanks very much for kicking the forum off. Thanks, Jane.
Thank you, John, and thank you for the opportunity to be here. I would also like to acknowledge the traditional owners of the land on which we meet, the Gadigal people of the Eora Nation, and pay my respects to their elders past, present and future. My name is Jane Costello, as John said, and I'm the President of Positive Life New South Wales. I want to begin this talk by stating up front that HIV infection remains a difficult and shocking experience for most people who receive a diagnosis. Many of these people encounter ongoing challenges in life as a result. However, they also meet and overcome these challenges in resilient and creative ways that offer inspiration to others, including to other people living with HIV. HIV is manageable, and it must be acknowledged that living with HIV in 2014 is very different to what it was like in the 1980s. The impact of HIV-related stigma and discrimination is a differential experience, however, which varies from individual to individual, context to context. And as such, it is difficult to discuss HIV-related stigma in generalizations. Since the earliest days of the epidemic, HIV-associated stigma has been recognized as a serious and debilitating feature. It has also been recognized as a major obstacle that inhibits prevention and access to treatment and care, but I'll come back to this point a little later. There are a number of reasons why HIV is stigmatized. It is a serious communicable disease. It is linked to sex and drug use. There is a hangover and community memory of the shocking consequences of HIV from the early days, and it overwhelmingly affects most populations who are already socially marginalised. In 2010-2011, the National Centre in HIV Social Research, now CSRH, in collaboration with NUAA, the National Association of People with HIV Australia, conducted an investigation into HIV stigma. They focused on the experiences of people living with HIV in relation to HIV-related stigma and discrimination. Although results confirmed the experience of HIV stigma among the study sample, it could be described as moderate rather than severe. On the whole, women and heterosexual men tended to report higher levels of stigma than gay men, and the entire sample reported higher levels of felt stigma rather than enacted stigma. This was either described as a perception of others' negative attitudes or as feelings participants had about themselves. The difficulty in addressing perceived slights or negative attitudes of others is that it's difficult to always say whether these perceptions arise in response to something real or not. The reality is that most explicit stigma or discrimination is generally considered socially unacceptable. This fact may be a sign that attempts to combat HIV stigma and discrimination towards people living with HIV may have had some degree of success in Australia. The fact that explicit discrimination is relatively rare can be counted as an accomplishment stemming from decades of effort put into enacting anti-discrimination legislation and creating cultures of equal opportunity. It is nonetheless doubtless true that some individuals in society do retain stigmatizing beliefs about HIV, and some people living with HIV have highly attuned senses for detecting these attitudes. Their subtle nature, however, often makes them almost difficult to question or challenge. While it may be difficult to combat and change these attitudes in others, it may be more realistic to consider how these messages are received by people living with HIV. This is why the idea of resilience is so appealing. It offers a way to abate the power and negative impact of stigma. The negative feeling and attitudes that people living with HIV hold about themselves are worth examining. Because the transmission of HIV is primarily linked to sex or drug use, many people living with HIV internalize negative beliefs about themselves and therefore live lives of shame, fear, and self-loathing. The metaphors of dirty or unclean to describe how HIV makes some people feel was found to be strikingly common in the study. The fact that some of the most stigmatizing attitudes and beliefs about HIV are held by people living with HIV means that mounting campaigns to influence the broader population may be unlikely to address the problem. Challenging negative beliefs that people with HIV hold about themselves would seem to be a more effective pathway to peruse, particularly challenging the self-stigmatizing beliefs of being dirty or unclean because of HIV, and therefore building personal resilience. Then there is the issue of criminalisation of HIV, non-disclosure, exposure, and transmission. The overly broad application of criminal law to HIV non-disclosure, exposure, and transmission raises serious human rights and public health concerns. I believe that we need to concentrate on expanding the use of proven and successful evidence-based and rights-based public health approaches to HIV prevention, treatment, and care, and to limit the application of criminal law to the intentional and malicious transmission of HIV cases where it is needed to achieve justice. We need to strengthen HIV programs and empower people with the knowledge that enables them to protect themselves from HIV and to avoid transmitting it. And we need to help people to access the services they need for HIV prevention, treatment, care, and support. We also need to accept that HIV infection is now a chronic, treatable health condition. It is inappropriate for criminal prosecution of HIV non-disclosure, exposure, or transmission to involve charges of inflicting grievous bodily harm. The fact that the law continues to represent non-disclosure, exposure, and transmission in such a serious and exaggerated way misrepresents the impact of HIV infection and stigmatizes people living with HIV, as well as hindering public health programs. So how does stigma affect HIV prevention and treatment? HIV stigma adds to the stress experienced by people living with HIV, whether HIV is diagnosed or not. In addition, it leads to challenges in HIV prevention efforts. Fear of the negative social consequences of an HIV-positive test result can deter some people from getting tested. Studies in the US have found that stigma is associated with a decreased likelihood of being tested for HIV. People who are HIV positive but haven't been tested and don't know they're HIV positive are less likely to try and prevent transmitting HIV to others. Some HIV positive people may fear that disclosing their HIV status may bring partner rejection, limit sexual opportunities, and increase the risk of social and sexual isolation. Stigma surrounding HIV, sex, and drug use makes it difficult for HIV prevention services to be maximised. While it's accepted that HIV prevention should be integrated into the broader health and community contexts, many parts of the community, such as faith-based institutions, businesses, prisons, and schools, have resisted having frank discussions about HIV. Stigma can also negatively affect the health and well-being of people living with HIV. HIV-positive people may disengage from healthcare and not seek treatment, or delay going to a doctor due to real or perceived discrimination against them, and the fear that HIV infection will need to be acknowledged not only by them, but by their partners, family, and associates. This may particularly be the case for people living with HIV who are heterosexual, bisexual, or who come from Aboriginal and culturally and linguistically diverse communities, where knowledge and acceptance of HIV may be limited. These persons may not have an adequate support network because they fear that friends or family will abandon them or suffer the same stigma as they do. Studies have found that for some population groups with high levels of internalized stigma, these populations avoid seeking testing, treatment, and care because they're afraid of disclosure and see themselves as unworthy of receiving support. Experiences of social rejection, disapproval, and discrimination connected to HIV may decrease the motivation of people living with HIV to stay healthy, to seek treatment and care, or to remain connected to healthcare services. Those who experience stigma are also likely to miss clinic appointments and lapse in adherence to their medication. These factors have repercussions for efforts to maintain health and reduce individual and community viral loads and prevent onward transmission. We live in a new era. Knowledge about HIV prevention, transmission, and care can offset the stigma that is caused by misinformation and ignorance. Education programs are needed in many areas and populations and will continue to be needed for successive generations of young people if we are to achieve the goal of eradicating HIV by the end of this decade. Stigma exists not only within individuals and their actions, but within broader social and cultural contexts that need to be addressed. Organisations and communities must tackle the values, norms, and moral judgments that contribute to the stigmatisation of HIV-positive people by faith-based organisations, businesses, lawmakers, and opinion leaders. Policymakers need to consider the potential consequences of legislation to ensure that they don't inadvertently increase HIV-related stigma and discrimination and undermine public health initiatives. We must involve people living with HIV in the designing, running, and evaluation of education and stigma reduction programs. These programs can offer cultural competency, confidentiality, and awareness training for healthcare workers, counsellors and staff at social service organisations, including drug treatment, housing, mental health, and community and residential aged care services. HIV stigma is unlikely to go away anytime soon. But as new knowledge and understanding about the reality of infection with HIV becomes more widely understood, it is hoped that the enacted and felt stigma will reduce, and so too the impacts on people living with HIV. But to achieve these potentials, we need to step back from a necessity to dramatise an HIV diagnosis into something more than it needs to be. The HIV sector is complicit in this behaviour, and it's unhelpful. It's a controllable virus, and we need to get real about that. If you happen to be infected with HIV in Sydney in 2014, chances are you'll go into treatment within 6 months, have an undetectable viral load pretty soon after, and live an remarkably normal life with a job and a partner and family who love you. Continuing to dramatize infection with HIV into something more may suit some involved in implementing the HIV response who see the value in HIV-related stigma as a preventative mechanism, but it doesn't represent the modern reality of living with HIV, and it increasingly won't. Thank you.
Thank you very much, Jane, for that very powerful reminder of how stigma, discrimination, and criminalisation continue to affect the lives of people with HIV, broader communities, but also talking about sort of your thoughts, sharing your thoughts as to how we can go about tackle stigma and how stigma sort of affects and is affected by the changing environment in which we live and sort of is a barrier to the use of all technologies that we have, but may also be reduced by sort of the development. So thank you very much for that. It's now my pleasure to welcome the panel for this afternoon's session. So can I ask you to join me up here, and I'll introduce you once you've all taken your stool, I should say. And that gives me an opportunity to flag with everyone that we've handed out the cards, and great, people are filling them in. For those who are onto technology, you can also tweet Carla. So there's a bit of an option here, and Carla is a very expert tweeter, so she's on it. So if that's more convenient, please go ahead and do that. So we'll have about sort of 45 minutes, an hour to talk with these our leading experts in New South Wales in the HIV response. And I'll start with Fiona Powder. Fiona is from NUAA. Do you want to say a couple of words about yourself, Fiona? It should be working if you just speak into it.
So, Fiona Powder, work for the New South Wales Users and AIDS Association. Previously worked for the Australian Injecting and Illicit Drug Users League, AVIL, and while I was there, we developed a stigma and discrimination program for people who inject drugs. So now I'm back at New South Wales. I run NUAA's Stigma and Discrimination Project, so I do a lot of work in training healthcare professionals around stigma and discrimination.
Thanks for that, Fiona. Craig Cooper, CEO of Positive Life New South Wales. Well, say a couple of words.
I think some of the priorities around stigma and discrimination for people with HIV in New South Wales, from my perspective, I think we need to be working more closely with, so community organisations need to be working more closely with health service providers and addressing stigma and discrimination that people experience when they're receiving or engaged with healthcare. So whether it's around testing, whether it's around access to your medications, whether it's around consultation sessions with your doctor, I think that's one of the main issues that we need to be starting to think about and working on more structurally and systematically. For example, if you turn up to a doctor's appointment, whether it be a 3-monthly or a 6-monthly visit, and your privacy is breached by admin staff at the reception counter. Those sorts of things occur on a regular basis, and I think there's some of the issues that we need to be working on.
Thanks, Craig, and I'll come back to that in a minute, looking at sort of what the main issues are that we face. Alex, Stratigos?
Stratigos.
Stratigos, sorry. The emphasis is always a bit of a challenge. from Alexandra is a solicitor with the HIV/AIDS Legal Centre in Sydney. Maybe you want to say a couple of other things about.
Sure. So without stigma and discrimination, I would probably be without a job. So one of the aims of today is maybe to come up with a way to make me unemployed.
Okay, good.
Yeah.
Well, okay. Yeah. That sounds good. Cameron Cox. Cameron is with the Sex Worker Outreach Project with SWAP. Cameron looks after the men and is an active sex worker himself.
Yeah, and I've probably been positive since it was about a 4-paragraph story in the New York Times and was called Grid. I've been a sex worker since I was at school, actually, so quite a long time. And just to speak to stigma and discrimination in that area, I'm probably the first HIV positive sex worker that you've seen in public. There's actually 2 of us now of today, but that speaks volumes.
Yep. It does indeed, and thanks for sharing that with us, Cameron. Alan Brotherton. Alan is the Director of Policy, Strategy and Research at ACON.
So this is just about us, yeah? So I've got many thoughts about stigma and discrimination, but they're all arguing with each other in my head at the moment, so I'll let them do that. So yes, I've been working at ACON for the last 3 years. I was diagnosed with HIV in 1986 and was convener of PLWHO New South Wales in the early 90s, which was interesting. And I guess one of the big things there was setting up the Positive Speakers Bureau, primarily as an anti-stigma intervention through actually getting people to meet and see people with HIV, and that seemed very effective at the time. And I guess, I've worked in a range of roles, nationally, internationally, in South Australia, which is neither. Yeah.
Thanks, Alan, and I'm sure we'll hear a bit more about positive speaking. Loren Brener. Loren is a Senior Research Fellow at the Centre for Social Research in Health, and you've heard a bit about her work when Jane was giving her opening address. Loren.
Thank you, John. So most of my research is around stigma and discrimination with people living with HIV and with hepatitis C, and I was involved in the research that Jane spoke about, as John mentioned. And I'm also currently involved with research running that Fiona's involved with at NUAA, looking at internalised stigma. So the focus of my work is how people, what impact the experience of stigma has on their health outcomes.
Thanks, Loren. I just want to do a sort of a first round of sort of Q&A with the panel, sort of starting sort of at the beginning and picking up where Craig was leading us into, sort of looking at stigma, discrimination, criminalisation affects the lives of people with HIV, and other types of stigma affect the lives of people with other conditions, but focusing on HIV. Craig, could you go back a bit to sort of what you were saying about how stigma, discrimination, criminalisation play out more sort of prominently, the things that you sort of that stand out from your perspective?
Yep. So the issues that stand out would be, for example, if there's fear of being prosecuted around your HIV status, whether it be intentional or unintentional transmission, then what that does around a person's ability or perspective around disclosure of status, or how that then impacts on somebody's ability to negotiate in a drug-using or a sexual encounter. So that's one of the issues, I think, that impacts on somebody's ability to talk about their HIV status and then also appropriately negotiate a drug-using or a sex encounter. The other example that I gave was around regular breaches in privacy when you're coming into contact with service providers, and how that potentially creates difficulties for you in interacting with staff within a clinic, or even at times turning up for appointments. So whether that be for a blood draw, whether that is around just ringing up and negotiating an appointment to go and see your doctor, whether that's going into a pharmacy and collecting your medication. You're constantly, well, I'm constantly in a position where I have a level of discomfort, knowing that something is likely to occur. It doesn't occur every time. It may only occur, say, 1 out of 6 or 1 out of 10 times that you go to your healthcare provider. But there is typically something that happens. So, for example, when I was getting care up in Darwin, I was disclosing both my drug using and sexual activity with my prescribing doctor at the time. And that immediately went onto my file and changed the way that clinical staff were interacting with me as a result of that disclosure. So it's that sort of stuff.
And if I recall, you also mentioned issues around sort of reception staff. Yep. I think that's certainly one of the things that might not always be on people's radar. It's those sort of casual, day-to-day sort of interactions with service providers. Yep. Alan, looking at sort of your broad expertise, what would you think are sort of the issues that stand out in terms of stigma, discrimination, criminalisation for the communities that you work with?
That's a huge question.
Yes.
So
we're going to resolve the problem tonight.
Oh, okay, good. Oh, well, so we better get on with naming and outlining it very clearly. Look, I guess there's a few things, and I guess I just want to comment, thinking about Jane's talk and this notion that a lot of the stigma that people express is self-stigma, which I think is interesting, but what I think is, well, where do people draw self-stigma from? It's not as though you get a disease and you just automatically and naturally feel incredibly bad about yourself and shamed for doing it. You must be drawing on cultural cues that are out there in wider society. And it's probably the things that are said about people with HIV. And I think, you know, there hasn't been a lot in the way of public discourse and public narrative about HIV in Australia in recent years, but actually I did my master's research topic on the HIV immigration debate that blew up in 2007, which was one of the very few big public debates, and the attitudes were really quite shocking. People weren't particularly excited or wound up by the Michael Neal case, which was what led to this. It was a bizarre process. I don't know if people know the Michael Neal case, a guy in Victoria who was charged with a number of offences. He was actually never charged with any kind of deliberate infection, incidentally, but that was what the story was about. Got lots and lots of coverage in the Herald, lurid headlines, you know, HIV man, registered sex slave as dog with counsel was one of them. That was, they actually didn't get much public interest at all. And there's a myth in the community sector that defined how people read people with HIV. But Bronwyn Pike, who was the New South Wales Health Minister, blamed the issue on immigration of rising infections in her state. Now, the immigration turned out to be from New South Wales, but so that was rubbish. But John Howard picked up on that and said he didn't think people with HIV should be allowed to immigrate to Australia. And he didn't realise that they were. And that then kicked off this extraordinary debate. And if you went through the newspapers, they were, I mean, really, really offensive kind of stories. And inevitably, the person with HIV immigrating was African. Like, it never seemed to occur to anybody that it might be a financial advisor for a European bank, for instance. And Africans were always going to despoil and our women folk and daughters. I mean, incredibly old-fashioned notions of cultural pollution and moral pollution. And I don't think that there have been a lot of larger public debates since. So when I think, well, so what are the cultural cues people have on which to draw knowledge of themselves in relation to their HIV infection? I don't think it comes from within, and I do think it comes from without. So I suspect we live in a not particularly accepting social environment, but we just don't see it because we don't call on it very much. So I'll leave that point where that is. I've got lots of other things to say, but we can get to those.
Thanks for that, Alan, because it gives me two ideas as to sort of immediate thoughts as to how we're going to continue. I'm going to go to Alex first, and then I'm going to go to Loren. So Alex, so maybe we can get you out of a job by the end of the day, but I'm pretty doubtful we'll actually manage that. But picking up on what Alan was saying around sort of HIV and migration, or HIV and sort of people moving and mobility a bit more, that's an area where you are very active, and where HALC is very active, and maybe you can tell us a little bit about what you're experiencing in that space and what you're doing in that space as well.
Yeah, sure. Well, there's been a lot of problems that I've noticed with clients being really fearful engaging with the migration process because of the significant difficulties in obtaining residency to remain in Australia. I'm sure you'll remember from a few years ago, there was a man in Queensland. He was known as the acrobat. I'm sure that you'd all have heard about him. So he actually, on his medical examination, when he was applying for a permanent visa, he'd asked somebody else to go for that medical examination for him. Part of that later formed the brief of evidence that was put before the Queensland courts. But he was so terrified at the prospect of having to return back to Zimbabwe, which is where he's from, that he was really fearful in engaging with that migration process. And it's clear that he had a whole range of issues that he was dealing with internally, I suppose, in terms of stigma and discrimination that he would have faced as being a sub-Saharan African male, for one, and in that sort of cultural context. So, for instance, he was diagnosed in 97, and then he again, in 1998, he again went and got tested and was diagnosed, but he was going for a test. It's not like he was going to engage with a doctor to treat his HIV condition. It was to confirm whether or not he was positive. And then from 1998, then he did not see any doctor. He did not go to see an HIV specialist at all until actually after all these court proceedings and everything came to light. So I think if, that's looking at both the criminalisation aspect as well as the migration, and he just seemed sort of so paralysed. He was sort of trying to just deny that to himself as much as to anybody else that he was HIV positive. And I don't see really in that case, say, the victim in the matter, or the community or anyone really getting anything out of that conviction.
Thanks, Alex. So just a follow-on question. Sort of, to what extent, sort of, in your knowledge, is this sort of the Australian situation around sort of regulations around entry, stay, and residence different in Australia from other places in the world?
So our restrictions are very different from countries we like to compare ourselves to in Europe, for instance. Most of the European countries don't have any restrictions on people entering or remaining in those countries. The US, it's no longer, HIV is no longer a barrier since 2009 to people entering or residing in the US. We have sort of comparable laws to Canada and New Zealand, however.
Thanks for that. Loren, I just wanted to come to you to sort of explore a bit more, sort of when Alan was talking about sort of how do people pick up sort of those subtle signals that you're different. I think Alan rightly noted that the self-stigma comes from other places, and from your work in particular also with the service providers. Do you have some sense as to how that process works?
Well, one of the things that struck me when you were speaking, Alan, is that and I think what Jane said earlier, that we often, it's not acceptable to express overt kind of racist or stigmatising attitudes. So people don't express that overtly, but there's a growing body of research that is looking at implicit processes and looking at things that kind of occur for people at an unconscious level. And that tends to show that people's attitudes are quite different. The attitudes that they hold unconsciously or that is outside of their awareness, and usually tends to be quite a bit more negative than the attitudes they consciously express. So I think it's that kind of body of research that certainly shows us that these attitudes exist out there. And even though perhaps we're able to combat the conscious attitudes that people have, we need to, I think, possibly, and don't ask me what, but we have to come up with different strategies to address the unconscious or implicit attitudes that people have.
Yes, please, because I was coming to you.
I think for people who inject drugs and living with BBVs, and it's a term that we talk about, and it's part of that implicit or inherent attitudes, is microaggressions, so the small slights, the looks. We feel or we know or we perceive that we're going to experience some form of discrimination. It may not be particularly related to that incident or that person, but it's perceived and taken on as that. Some of the work that Avel has done in market research around why people stigmatise drug users is around the fact that they're scared of us, scared that they're going to catch either drug use or a BBV, that we're contagious, and also that stigma and discrimination is good for us, against us. That way it'll stop people behaving in certain ways, doing particular actions or taking drugs or having sex or whatever it may be. So it's stigma is good. But we've also got to remember stigma and discrimination have been around since society has been there. We've always got to have a baddie.
I think you're absolutely right, Fiona. It's a very sort of deeply ingrained social mechanism, but the issue is always how it plays out and who gets affected and how, as a society, we deal with it. But we'll get to that sort of in a bit. So thanks very much for sharing, because a lot of the work that Loren does in terms of her research also intersects with viral hepatitis and sort of quite a lot of overlapping experiences. I want to go to Cameron, because sex work, STIs, HIV, that's an explosive mix, isn't it, in the public's eye?
Yes, it is. Sex workers walk on eggshells most of the time. HIV positive sex workers especially so. The amount of vulnerability we have to blackmail violence, I have no idea what, because I just stick it right in the back of my head and try not to think about it. But there aren't really out HIV positive sex workers advertising. If they do, they advertise in closed spaces or by word of mouth or serosort, or they don't disclose that they're HIV, and usually do services that are less risky than full service, and quite often they tailor those services so that those services avoid breaching Section 79 of the Public Health Act. It's a really difficult area.
So can you explain for us laypersons what Section 79 of the Public Health Act is? In
lay terms, yes. It basically says that if a person with any of the scheduled STIs, but it's aimed at HIV, so if you're infected with HIV, before you have sex, and sex is defined as penetration of the penis, of an anus, vagina or oral penetration, plus cunnilingus for reasons I don't quite understand, you must tell the person that you're HIV positive. You must inform them of the risks of the activities that you're going to indulge in. So you have to have a bit of a crystal ball, and you have to get informed consent. What's basically informed consent? It's a law that's never been quite tested, and it now also has a defence of safe sex, which is also not very well defined. Okay. So again, even if you are across that, you're flying a little bit blind.
Yes, so it's a very sort of difficult space to work in.
It's an extremely difficult space, and that section is used more for blackmail than it is, I think, for public health reasons.
Well, it does sort of, certainly you can see how it creates that vulnerability.
Correct.
Yep. Thanks. I'm going to hand over to Carla, who's been on to the questions from the audience. I'm going to give you my mic.
I'm going to ask one question now, whilst then I'll see if people have questions that I can curate over to the audience, just as we have one mic here today. So first of all, I'm going to ask the panel to comment on questions of layered stigma, because we've heard people talk about not just HIV, but other identities and practices and roles and jobs and cultural backgrounds that may all create a very messy environment of stigma. How do you approach those in your own work and your own responses? Who'd like to start with that? Easy one.
Do you want me to do it? Because I come from a community where we can sometimes claim all of them all at once. We have something that sex workers call whorephobia, and it's the equivalent of homophobia. So most people understand what homophobia is. It's sort of the irrational dislike, fear and hatred of people who are same-sex attracted. We have whorephobia, which is the irrational dislike of people who do sex work, and it really does exist. It's a very deep stigma in the community, and it probably goes back hundreds of years. So sex workers have to deal with that. They are often from cold backgrounds, so there's a whole pile of racism that comes into it. Most sex workers are female, so they get some stigma from that direction. We've also been named as vectors of disease, I think, for thousands and thousands of years. As soon as there's anything that happens from plague to the pox, it's the sex workers that are spreading it. And that's also a very, very deeply ingrained social trait. I can remember my mum telling me when I was about 17 to stay away from loose women and prostitutes, not knowing that her son already was one, but...
a loose woman?
Yeah, yeah. So... And I've got a great collection of posters from the war in the 30s and 40s saying, loose women and et cetera, et cetera. So that's deeply ingrained. And of course, when HIV came along, we were one of the very obvious scapegoats apart from MSM and injecting drug users. And that still goes right through the law at the moment. What else can we be stigmatised for? Our injecting drug use, which is about the same rate as non-sex workers, but it's assumed that we're all injecting drug users. We're not. I am, but most of my colleagues aren't. And just before I forget, I'll mention that Scarlet Alliance in 2008 did a needs assessment of HIV-positive sex workers, and it gives stories of other HIV-positive sex workers that were obtained there. It's got some recommendations, and it's quite an interesting read. Even Scarlet Alliance, doing it blindly and anonymously and with peers, with HIV-positive sex workers going out trying to recruit, could only manage to get 12 people to fill in forms.
Alex, what about in the legal environment? Do you need to drill right down to the nub of the issue that might be provoking discrimination when there is a whole lot of things in someone's life that is putting together their full package of experience?
Yeah, it's really important that we do work out exactly, I suppose, what the treatment or the stigma and discrimination was directed at, particularly if we're commencing legal proceedings. We're going to have to particularise exactly this person was treating you, like X or Y because of your HIV status. And then they'll turn around and say, no, it wasn't because of their HIV status. It was because of them being on treatment for the condition. And then later on, then we're somehow throwing in, oh no, it's actually because they're a woman and they're breastfeeding or something. Like it just there's so many layers, and then you've then got to try and work out as well what the damage is caused by. So I've got a discrimination matter running at the moment where it's a Fair Work complaint, so it's a workplace discrimination, and they're saying, no, she hasn't suffered damage because of the way we've treated her. She has to take responsibility for the fact that the way she's feeling is actually because she's been recently diagnosed and she's just not coping with it, and she's got to own that. That's not on us. So when we come down to later on calculating the damages, it's going to prove to be difficult. It's like, what caused what?
Alan, have you got something to say on layered stigmas and identities and practices?
Okay, layered, yes, or selective. I mean, look, what I'd say, and I guess I'm drawing on having worked internationally around this, is that there's always HIV stigma, but there's often stigma about the mode of transmission of HIV, but that's going to vary from culture to culture. So in the Middle East, in Arabic cultures, drug users actually tend to end up at the bottom of the list at the top, at the top of the list at the bottom. So ordinarily, you'd probably say globally, it goes, gay men generally, assuming they're reasonably respectable, sex workers, drug users, but it shifts around, and it's really interesting. And the cultural origin, as was explained to me, is that there's a history of drug use and it's actually seen as something over which you have no control, whereas sex work and homosexuality are actual choices you make, so you've chosen to be sinful, and that is what attracts the stigma. In terms of, therefore, the HIV and how that plays out, I mean, look, it varies so much. I mean, we are doing some work when I was at the Alliance with our partner in Peru, and it was about building a coalition of sex workers, MSM, and people with HIV. And the people with HIV group said that they were very anxious about this because they hadn't worked together with groups of sex workers and MSM before. What's intriguing is that 95% of people with HIV in Peru acquired it through sex work or sex with men, but had decided to live in the space of people with HIV because that actually attracted less stigma. So people can separate those layers tactically and strategically, whether that's a good or a bad thing, but people do that. But what that does suggest is those layers are there.
So while the panel's still contemplating this issue, I just wanted to open it up to the floor. Because we do have one mic, I'm very happy to take your questions so we can record them via the mic. So just let me know if you need to ask a question. But anybody else want to comment on layered stigma?
Personally, I would hate to be an Aboriginal person living with HIV as a woman who's pregnant and injecting drugs. We anecdotally have heard of a number of pregnant women who come from Aboriginal backgrounds who actually go into hospital or have their babies under a different surname. So because of that fear of having their children taken away, it may have happened to their sister or their mother or the like, but there's so much fear around that, which is based on the stigma, that this is what they feel compelled to do.
Thanks very much, Fiona. And do please hand Carla any questions you might have, or tweet them to Carla, because I want to sort of take the panel into the next step, sort of having explored somewhat as to how stigma plays out in people's lives, affects their lives. Wanted to start looking at what are we doing to sort of fight stigma and the fallouts of criminalisation and discrimination. And Fiona, I wanted to start with you, if that's all right, because you already alluded to some of the work you've been doing with AVIL and some of the work you're probably doing in New South Wales. Maybe you can talk a bit about
that. The drug user movement in a few years ago now realised that not much had been done since sea change in relation to stigma and discrimination, and that was 2001, and not much had changed since that time. And so what we did was we did some market research and looked at the reasons why the general community hates us, and why they discriminate against us, and the reasons behind that, and looking for ways to address that. That was followed by the development of a document called "Why Wouldn't I Discriminate Against All of Them?", which came from the market. The title came from the market research. And it was actually a member of the general public who had been shown a picture of all these different people, and there was a gays and people who inject drugs and the like, and he's basically, I discriminate against all of them. So what we found anecdotally was that the majority of the stigma and discrimination that people who inject drugs were experiencing was actually in the healthcare system, and that had the greatest impact on us. So we decided to do a whole lot of different things to reach different populations, and we looked at the media and stigma and discrimination against people who inject drugs, developed a short film. We developed that document on the history of stigma and discrimination and how it manifests in contemporary society. We addressed issues of stigma and discrimination against people who inject drugs so that they could report those instances on a web page, and so we'd have some evidence to use. And here in New South Wales, we've taken that a bit further, and we work with people who inject drugs around self-stigma and what that means and what they can do to address some of that and recognise that. And probably the largest thing that we've been tackling is targeting healthcare professionals and students as the healthcare professionals in the future, with workshops and training, cultural competency around this, these issues of stigma and discrimination, what people can do in their lives and their professional lives, looking at language that we use, all sorts of those sorts of issues, addressing those.
Thanks a lot. That's quite a comprehensive response that you're talking about there.
Yeah, it's nice, honest work.
Yeah.
It's great when you see people's attitudes changing.
Yep. We'll come back to the funding, I suppose, so how do you pay for this work in a bit. Craig, I saw you nodding. Maybe you want to talk a little bit about sort of what's happening for people with HIV.
I think what we're doing well is developing resources, community campaigns, one-on-one peer support to assist people, workforce development with clinicians. So on a community, grassroots, individual level, I think we're doing some things. I don't think we're doing as much as we could be, but I think we're doing things quite well in an overall or a general sense. I think the problem is that we're not dealing with the quantum or the structural issues. Like we've got drugs are still criminalised. There are still jurisdictions in Australia where sex work is either regulated or criminalised. People with HIV are still have restrictions placed on them in terms of what services they can or can't access, depending if whether they're an Australian resident or not, and in terms of immigration or travel around the globe. So structurally, whether it be legislation or policy or whatever, I don't think we're doing all the things that we could be, and I don't think we're going to get on top of stigma and discrimination the way that we need to be. We're going to be doing all of this grassroots, community, ground-up stuff, but while all this other stuff's still going on, we're in trouble. I don't think we're going to get the shifts that we need to.
Thanks, Craig. I want to zoom into two sort of structural things, starting with sex work first, of course. Thanks, Alex. So,
do you want me to follow on?
Yes, please.
Will definitely agree with Craig. It's that area 4 in the Melbourne Declaration that's not really moving. Yep. And it's what within the financial constraints that we have, we do as much as we can. But most of our work is one-on-one peer outreach with sex workers, and there's not much left over. We do sensitivity training for anybody who asks, as long as we have the time. We go to local area commands and sit in front of 60, 80 coppers who think they know it all about sex work and persuade them that they don't. We go to sexual health clinics right throughout New South Wales, both to check up on what's happening in the area, but also to make sure that they are sort of doing it right so that sex workers can come in and feel comfortable. And they're bloody amazing, most of them are. We go to other clinics, this is part of, that sort of program. I'm out here now giving a face to sex work, and we do that as much as possible. Now that we're independent, we also engage directly with the media and with government. We spew stuff out on social media as much as we can, trying to show that we're just part of the general community and just another occupational group. We fight very hard for the correct use of language. The use of the word sex worker instead of the term prostitute is one that we work very, very hard on, and we've had some success, and it's something that really does change attitudes. As Newer pointed out before, but without core funding in our peak organisation, we're pretty well hamstrung in a lot of those areas.
Yes, and that funding issue sort of is hanging above the organisations for quite a while now. Yes, Cameron, what's happening in terms of the review and possible changes to regulatory models of sex work in New South Wales?
Here in New South Wales, hopefully it's stalled, but the Sydney Morning Herald, as you might have noticed, must have got bitten by a sex worker when it was young or something, because it has a pathological hatred of us at the moment, or some of its journos do. And they're continually running stories calling for the government to honour its promise of considering a licensing model. The government has honoured its promise. It's considered it and thought it was a really bad idea, but we're always fighting against regulation, Swedish model, people wanting to bring in something to fix the problem of sex work when we're not actually a problem, we're the solution.
Thanks, Cameron. Alex, I wanted to go to you because of what Craig was also saying in the migration space. So are we seeing any positive changes in that sort of policy area? Perhaps some good things have come out of the Melbourne HIV conference earlier in the year?
Yeah, so after the conference, I'm not sure if some of you saw the report that we put out with John also co-authoring that as well. And
blatantly.
What our report was pegged at, it was commissioned by UNAIDS, and we were asked to look at the migration regulations and laws in Australia, and also how that fit in with the overall sort of global review that looked at what was, I suppose, best practice. Australia doesn't have specific HIV related restrictions. We have restrictions on all people with disabilities. We discriminate against everybody with a disability, so we're really good about that. Unfortunately, because the I suppose more global review looking at best practice talks specifically about HIV specific restrictions, we were then seen not to be needing to make any specific changes. But coming out of the conference in Melbourne, we're looking at maybe engaging in further discussions with sort of international groups about, again, looking at those more global best practice guidelines and seeing if they can be shifted to try to shift other countries, not just Australia, but places such as Canada and New Zealand as well, to get some bigger changes.
So, and tell me, when clients come and see you and then they go through that complicated process of sort of seeking a visa or permanent residency permit, so how often do people sort of not get a visa awarded?
Yeah, I don't let people go home, so we come up with a pathway for them. It's usually complicated. It's going to take a lot longer than any migrant that doesn't have a disability, but we'll get them there sort of in the end. It's worrying if there are some migration agents or solicitors out there who are maybe not aware of all the intricacies involved in the migration regulations around the health criteria, and prepared to guide their client down those complex pathways where if you're paying somebody, it's going to be expensive because they're complex. They're going to involve, not just the one visa application that someone might need, but a whole suite of applications to get them to that point. Yeah.
So you're saying that ultimately the outcome, if people work with you, can be quite positive, but they have to spend a lot of money or there's a possibility that they have to spend a lot of money along the way, not on you.
Yeah.
You should add.
Yeah, it's possible that, we're a free service, so we don't charge people, but if, they've got some money, we'd refer them to a private migration agent, and it's not really fair that they're then going to have to pay significantly more to ultimately get to stay here. And I mean, sometimes it does just get to the point where people just don't have those options and things. And it also, with, say, migration agents who are not as familiar with the health criteria, say for instance, you're applying for a business-sponsored visa that has a special health undertaking process that an employer can provide for a temporary visa, then the migration agent is sometimes of the impression that they have to disclose their HIV status to their employer. So, for instance, the other day I was talking to a migration agent about this issue, and the client works as a chef in a nursing home, and she was worried about saying, oh, don't you have to disclose to the employer because, they're working around like old sick people. And I'm like, well, I really think if he's operating on the residents, I think that's kind of a bigger issue here. So, but it took like a long time to convince her of this, and that she didn't need to be disclosing this poor guy's HIV status to his employer.
So it's not only where you work, but certainly what you do for what you do for a living.
Yeah.
The type of work you do.
Yeah.
Alan, you've been patiently waiting.
No. That segues nicely in terms of what we've been doing. So I guess ACON is in terms of broadening out our agenda and the LGBTI health agenda, we do a lot of training with service providers, and there's always a big component of HIV awareness there. And the aged care sector is actually the one sector that's taken up most of our training, partly because we got a pretty substantial block of funding to do that. So that hopefully might start to change the environments in those places. It's challenging because there's very high staff turnover. So that's one of the things. I guess the other thing is also in our HIV prevention programming, and it's going to be very interesting to see how Treat Early plays out. So we've already seen that HIV positive men in research are much more confident of the preventive power of treatment than HIV negative men, and that's actually a real concern in terms of, I guess, making early treatment appealing to those men who may become positive in the future. And it's always really intriguing that you recall when we had the rise in infections, we had the campaign that said the person most likely to give you HIV doesn't even know he has it, and that is in fact a truth. Possibly the most infectious people are highly viremic people in primary infection, and despite the fact that a person with HIV who knows that is on undetectable viral load is highly unlikely to pose a risk, I still think somewhere in the back of people's minds is because you've got it and the other person may only theoretically have it, somehow makes a difference and a distinction. I don't know we understand that very well, and it'll be really interesting to see how the Treat Early campaign plays out. But just in terms of the healthcare sector, just one little point, and discrimination's still going on, and I think it is an issue that needs to be taken up, possibly by Positive Living. But I've been to hospital quite a bit in the last couple of years. I've been in 10 times, and big waste of money. I still look exactly the same. But each time, of those 10 admissions, I've been last on the list 9 times.
Okay.
And, a few times you'd go, okay, but 9 out of 10 you start to think, what's going on here? And I actually had one surgeon say to me, I know there's risks involved in this surgery, but do you present a risk to me? Which was an interesting moment when I asked him to explain why, and did he not use universal precautions.
Yeah, you should call me.
Yes. Well,
yeah.
You're actually sort of 10 meters away from each other. Yes, thanks, Alan. Yeah. So we have Philip. Oh yes, I'm going to have to give you my mic. Here you are.
Thank you. I think it's been interesting, the discussion about some of the structural responses to discrimination that have been discussed. And I think those sorts of structural responses over time certainly can have an effect on reducing stigma, but I wondered if the panel might reflect on things that happen perhaps more in the social or cultural sphere. And I was just thinking about how in America in particular, I think there have been some very high profile people who have come out as HIV positive. That's happened a little in Australia, but I think perhaps a difference between America and Australia has been that there's been a lot less of that. I guess I'm interested in what people think the value of that sort of thing may be, and other types of social and cultural responses.
Thanks a lot, Philip. Fabulous question. Who wants to take it on? I've given someone a microphone because I think I can ask you something about that.
People can disagree with me. I mean, I think those kinds of high-profile people with HIV coming out are very powerful for changing general community attitudes. I think they're probably very reassuring and inspirational for some people with HIV. It probably encourages conversations around, for instance, their families of origin and friends that you would hope would make them feel better, but it may not. At least they'll know where people stand. But I think at a micro level, there's a lot of, still we see, I mean, even though rates of disclosure are going up, which is good, but we also see have seen in research very high rates of rejection. So, you know, the research to which we haven't asked for a while, and it would be interesting to ask it again, do you expect your sexual partners to disclose their HIV status? Yes. What would you do? And 68% of people say, well, then I'd reject them. And I think, you know, unless, I don't know the last time that research was done, but it is quite a while ago, and it would be interesting to revisit that and see where that is, because it's that interaction that is most important, both to preventing HIV, but also to addressing and challenging stigma.
Thanks, Alan. Just have to take the microphone off you because I was without one. In response to your question, we are in the process of doing an analysis like that, and you're sort of right in terms of the percentage. I'm happy to share. So, indeed, there's a lot of rejection. I gave a microphone to Craig and to Loren because wanted to ask you, Craig. Perhaps you can say something about what's happening in the positive speaking space, which is not exactly what you're talking about, but that's, I think, another mechanism, and then I'll come to Loren.
Yep, that's what I was alluding to before when I was talking about workforce development and also a bit more of a community movement at a community level. The Positive Speakers Bureau is typically booked for speaking engagements for a number of different reasons, schools, health facilities, that type of thing. We also target services, whether they be aged care or hospitals, if we get feedback from the positive community of things like Alan just described, where people have gone in under a general admission or a particular service, or with a particular presenting issue, and they've had a negative experience, so then we would approach the hospital or the clinic and suggest that they actually book a positive speaker. The Positive Speakers Bureau, in terms of people living with HIV going out into the general community and talking about what it means to live with HIV, is actually a really powerful way of doing that. While the conversation's been going on, I think I've been reflecting on some of the things that we've been talking about, and the thing that keeps on coming up for me is around shame. Is that in terms of slut shame, people who are very sexually out there and having a lot of fun, and whether that be through sex, drug use or both, that we're quite a conservative country and society. And I think the point that Philip raised, if there were more high profile people who were out and about being seeking pleasure and pursuing pleasure, being very sexually active and being very familiar with using drugs, I think that would help to deal with some of that shame that we have as a society. But overall, we're very conservative as a country, and I think there's a lot of shame going on. There's a lot of people shaming one another about all this. So I don't think it's just the legislative space, but I think we are shaming each other on a regular basis.
Yeah, thanks for reminding us of that, Craig. What I wanted to ask.
Can I pick up something about the Positive Speakers program as well? So I've been involved in doing research with Hepatitis New South Wales with their seen and heard speakers, which are speakers who have hepatitis C, and it obviously would be similar kind of findings to those with people who have HIV. And one of the things that is so key with positive speaking programs is that seems to be the things that healthcare workers respond to most positively, because they see kind of this real person who could be their sister or could be their aunt or could be their friend living with an illness, and they can identify with that. And so sometimes, while it is important for these high profile people to talk about their experiences, it's often the person who you can relate to as someone who you identify with that can make the biggest impact in terms of attitude changes. And also, one other thing just to pick up on something that Jane raised and has been spoken about, which is the issue of resilience. The other thing we found on the flip side of the positive speaking is the resilience that positive speakers themselves show in terms of being able to get up, talk about these things and combat stigma and discrimination themselves. And I think it's very important to focus on the attributes that people have that come from the stigmatized community, who are able to overcome that and, you know, get up and speak and combat stigma and discrimination.
Thanks, Loren, and it's very nice to see sort of how research and practice and experience sort of really sort of nicely dovetailed here. I'm wanting to sort of come to a bit of an end to the panel, because there is sort of an after the panel event that's awaiting us outside. But before we do that, sort of would like to hear from the panel members what you think, from your perspective, is the single most important challenge that we need to take on around stigma, discrimination, and criminalisation. Maybe I'm not going to start with you. I'm not going to be. Can I start with you, Fiona? Where I started
the biggest challenge. That's a huge one.
Yes.
It's absolutely huge. I think that it's probably around the idea that for people who inject drugs, that idea that we take on a lot of that self-stigma. We pick up on, or we know how society feels about us. We pick that up, we take it on, and it becomes that self-stigma, and challenging that is really difficult. And then the other next biggest challenge, I suppose, is structural discrimination. Our healthcare systems actually discriminate against us as well. Yeah.
Thanks, Fiona.
I think I'm a pragmatist. So I think if we're going to do anything that's going to have significance in dealing with both stigma and discrimination, it needs to be really practical, and it needs to change people's lives or the way that we operate in society as a community. So I think it needs to be some type of legislative reform or policy reform at a higher level, and it needs to have really practical application to our everyday life.
Thanks, Craig.
Yeah, I agree with Craig. I think you need to have something bigger, but from sort of a grassroots level, I think positive people just need to be empowered and aware of their rights and responsibilities, and so that they know how to react in certain circumstances, know when to disclose, when not to disclose. These are important things. So, I mean, we've talked about, you know, it being empowering for people to maybe be disclosing in the context of the Positive Speakers Bureau, but perhaps on a day-to-day basis, it's not necessarily going to be the best thing for them. You know, we get calls all the time talking about disclosure, and then, you know, their friend or, you know, former partner or someone is then writing horrible things on Facebook and these sorts of things. You know, once it's out there, so you need to be making the right choices at the time.
Thanks, Alex.
Yeah, well, we need public attitudes to change, and we need the structural part to change as well. And that's something that's got to sort of happen together. One won't happen without the other. We had law reform here for sex work quite a long time ago, and people who've been around that long will estimate that stigma went down by about 20%. Law reform alone won't do it, but if you don't have law reform, you can't do it. So it's a really difficult thing. You've got to fight on two fronts at once because they back each other up.
Thanks, Kevin.
Yeah, I agree with that. And what I guess the other thing is, in many ways, we do have a good legal framework, but it's a question of how well it's implemented. And I guess, you know, like there should be universal precautions. No one should be at the end of the list, but they are. So who's responsible for that? But I actually think, in terms of the biggest challenge, I think, Craig, you've identified it, and it's essentially, I think, if you look at the stigma that accrues to HIV, it's because people have been having fun with their bodies, and somewhere it's about, in a whole range of societies, negative views about pleasure and who is allowed to deploy their body and in what way and to what purpose. And so that's why there's, in, you know, even really high prevalence countries, like where there's 25% adult prevalence in Southern Africa, and yet people still will not talk about their HIV. I mean, there are communities in South Africa where 80% of the adult population has HIV, and it still carries shame and stigma. And I think that is extraordinary, and it's about an inability to recognise pleasure.
Thanks, Helen. Loren.
I think from a research perspective, while we've done quite a bit of work around stigma and discrimination, I think there's a lot we still don't understand, that it's really very complex. I mean, we mentioned layered stigma, we've spoken about internalised stigma, the stigma derived from the attitudes that other people have. And I think we need to start conceptualising all of these other issues as well, looking at implicit stigma, implicit internalised stigma. So we know the impact that it has on healthcare, people not accessing healthcare as much, or people not remaining on treatment. But I think looking at these other broader issues around stigma and discrimination, it really needs to be addressed to get a better idea of how complex, of this really, really complex phenomenon.
Thanks, Loren. And I'd like to thank the panel for their fabulous contributions and insights and thoughts, and thank you all for joining us. And I think sort of perhaps a final word. I think we've heard so much about the complexities, the intricacies, and the many challenges that lay ahead, but I do want to sort of also flag that it's very important that we continue to support the work of all these organizations represented here and the work that you all do. So I think that would be my main challenge for the near future, with very practical implications. So thanks again to all of you. There is food and drinks and refreshments just waiting outside, and there's lots of it, so do indulge as much as you can. Thanks very much.